Alterations in immunity. Hypersensitivity refers to an altered immune response to an antigen that results in tissue damage or disease. These reactions may occur immediately, such as in anaphylaxis, or they may be delayed, developing over hours or days. Hypersensitivity can vary widely in its presentation, but it always reflects an inappropriate immune response that harms the body instead of protecting it. Hypersensitivity reactions are categorized based on the underlying immune mechanism. Type I reactions are mediated by IgE antibodies. Type II reactions involve tissue-specific antibodies. Type III reactions are driven by immune complexes deposited in tissues. Type IV reactions are cell-mediated and involve T lymphocytes. Each type has distinct triggers, timelines, and clinical outcomes. Type I hypersensitivity reactions are IgE-mediated and are typically triggered by environmental allergens such as pollen, pet dander, or certain foods. In these reactions, IgE antibodies bind to the surface of mast cells, sensitizing them. When the allergen is encountered again, mast cell degranulation releases histamine and other chemicals, producing the symptoms of allergy. Antihistamines are often used to treat these reactions by blocking the effects of histamine. The clinical manifestations of type I hypersensitivity vary depending on where the allergen interacts with the body. In the gastrointestinal tract, symptoms may include vomiting, diarrhea, and abdominal pain. On the skin, it can cause urticaria or hives. When allergens affect the mucosal surfaces, they can lead to conjunctivitis, rhinitis, or asthma. In the lungs, exposure may trigger bronchospasm, airway edema, and the production of thick secretions. Some individuals have a genetic predisposition to developing allergic reactions, a condition known as atopy. Testing for type I hypersensitivities can involve food challenges, skin prick tests, or laboratory assessments of specific IgE levels. Identifying the responsible allergens is crucial for effective management and prevention. The mechanism behind type I hypersensitivity begins with exposure to an allergen, leading to IgE production. The IgE antibodies attach to mast cells, priming them for rapid activation. Upon re-exposure to the allergen, cross-linking of IgE on the mast cell surface occurs, triggering immediate degranulation and the release of histamine and other inflammatory mediators. This rapid release explains the sudden onset of allergic symptoms. Type II hypersensitivity reactions are tissue-specific, meaning that the immune system mistakenly targets and damages particular cells or tissues. The symptoms and clinical consequences of these reactions depend entirely on which tissues are affected. This type of hypersensitivity can be highly localized, but often causes serious functional disruption. There are 5 major mechanisms of tissue damage in type II hypersensitivity. The targeted cell can be destroyed by antibodies and complement proteins. Alternatively, phagocytes may engulf and digest the cell. Sometimes, tissues are damaged by toxic products released by neutrophils. In another mechanism, antibody-dependent cell-mediated cytotoxicity recruits natural killer cells to attack the target. Finally, antibodies may bind to specific receptors, disrupting the normal function of the target cell without destroying it, as seen in Graves' disease. This diagram illustrates how antibodies interact with cells and tissues to produce the various forms of type II hypersensitivity. Depending on the mechanism involved, the outcome could be cell death, tissue injury, or malfunction of a vital organ. Type III hypersensitivity reactions are immune complex mediated. In these reactions, antigen-antibody complexes are formed in the bloodstream and later deposited into blood vessel walls or tissues. These deposits trigger intense inflammation, as immune cells release enzymes that damage nearby tissues. Unlike type II reactions, type III hypersensitivity is not organ-specific. It can affect multiple tissues and cause widespread injury. Clinical manifestations of type 3 hypersensitivity include serum sickness, where immune complexes circulate and deposit in various tissues. An example is Raynaud phenomenon, where immune complexes cause vasospasm in small blood vessels. Another example is the Arthus reaction, a localized vasculitis resulting from repeated local exposure to an antigen, such as in celiac disease. These reactions often involve both systemic and localized inflammation. In type 3 hypersensitivity, immune complexes activate the complement system and recruit inflammatory cells. These immune cells release toxic substances that lead to tissue injury. Because these complexes can circulate and lodge in many different tissues, the damage is often widespread and can lead to chronic disease. Type 4 hypersensitivity reactions are unique because they are mediated by T lymphocytes rather than antibodies. Cytotoxic T cells directly kill target cells, while Th1 and Th17 helper T cells produce cytokines that recruit phagocytic cells to the area. These reactions develop over time, usually hours or days after exposure, and examples include graft rejection, the tuberculosis skin test, and allergic reactions to substances like poison ivy or metals. In type 4 hypersensitivity, the immune response is driven entirely by cells rather than circulating antibodies. Cytotoxic T cells and helper T cells interact with antigens presented by tissues, releasing cytokines that attract and activate macrophages and neutrophils. This creates a highly targeted but often damaging inflammatory response. Beyond the four basic types, hypersensitivity reactions are also categorized by the broader concepts of allergy, autoimmunity, and alloimmunity. Allergy is an exaggerated immune response to environmental antigens. Autoimmunity is when the immune system mistakenly attacks self-antigens. Alloimmunity is an immune reaction to the tissues of another individual, such as during a transplant or blood transfusion. Finally, immune deficiency occurs when the immune response is too weak to protect the host. Allergy refers to the immune system's exaggerated response to environmental antigens, known as allergens. Common allergens include pollens, molds, animal dander, certain foods, cigarette smoke, and house dust. Allergy is the most frequent form of hypersensitivity, and it is usually classified as a type IgE-mediated reaction. Even substances that are harmless to most people can provoke a strong, damaging immune response in sensitive individuals. Anaphylaxis is the most rapid and severe form of immediate hypersensitivity. It can occur within minutes of re-exposure to an allergen and can be either localized or systemic. Systemic anaphylaxis can cause airway obstruction, dangerously low blood pressure, and even death if not treated immediately. Common triggers include bee stings, peanuts, shellfish, and eggs. Desensitization treatments may reduce the severity of allergic reactions, but they carry the risk of provoking anaphylaxis themselves. Autoimmunity occurs when the immune system loses its ability to recognize the body's own cells and tissues as self. This loss of tolerance leads to immune attacks against normal tissues. Genetic predisposition, environmental factors, and random events all contribute to the development of autoimmune diseases. When self-antigens are mistaken for foreign invaders, the body's immune system launches an attack, resulting in chronic inflammation and tissue damage. Systemic lupus erythematosus, or SLE, is the most common autoimmune disease. It is a chronic, multi-system inflammatory condition characterized by the production of autoantibodies against a wide range of the body's own molecules, including nucleic acids, histones, ribonucleoproteins, and other nuclear materials. This immune attack causes widespread tissue damage throughout the body. In SLE, circulating immune complexes containing antibodies against host DNA are deposited in tissues, leading to inflammation and organ damage. The symptoms result from a combination of type 2 and type 3 hypersensitivity mechanisms. Lupus is far more common in females and often presents with periods of flare-ups and remission, making diagnosis and management challenging. Clinical manifestations of lupus are broad and can affect virtually every system in the body. Common signs include joint pain, arthritis, vasculitis and skin rashes, renal disease, blood abnormalities, and cardiovascular problems. Because the disease can mimic many other conditions, diagnosis often requires a combination of clinical assessment and laboratory testing, with a positive antinuclear antibody, or ANA, screen being a key diagnostic indicator. Alloimmunity occurs when the immune system reacts against tissues from another individual. This can happen during blood transfusions, organ transplantation, or pregnancy. The immune system recognizes the donor tissues as foreign and launches an immune response against them. The molecules that trigger alloimmunity are called alloantigens, and they are typically proteins found on the surface of cells, such as blood group antigens and histocompatibility antigens. Blood transfusions must be carefully matched because red blood cells carry specific carbohydrate antigens known as the ABO blood group antigens. Blood types are classified based on which antigens are present: type A, type B, type AB, or type O. If a person receives blood with incompatible antigens, a serious immune reaction can occur. Type O individuals are considered universal donors, while type AB individuals are universal recipients. If incompatible blood is transfused, the recipient's antibodies will attack the donor red blood cells. This leads to hemolysis, or the destruction of red blood cells, causing symptoms such as fever, chills, low blood pressure, and even kidney failure. Ensuring compatibility through careful blood typing and cross-matching is crucial to prevent these life-threatening reactions. Another important blood group is the Rh factor, which refers to antigens expressed only on red blood cells. People are classified as either Rh positive or Rh negative. Problems can arise when an Rh negative mother carries an Rh positive fetus. During delivery or late pregnancy, fetal red blood cells may enter the mother's circulation, leading her immune system to produce antibodies against Rh positive cells. In subsequent pregnancies, these antibodies can attack the fetus, causing hemolytic disease of the newborn. In organ transplantation, the major targets of rejection are molecules called major histocompatibility complexes, or MHCs, also known as human leukocyte antigens. Rejection is classified based on timing. Hyperacute rejection happens almost immediately and is caused by pre-existing antibodies. Acute rejection occurs within days to months and involves a cell-mediated immune response. Chronic rejection takes months or years and is characterized by a slow, weak immune reaction against minor antigens. Immune deficiencies occur when the immune system fails to function properly, increasing susceptibility to infections. These deficiencies can be primary, meaning they are caused by genetic defects present at birth, or secondary, meaning they are acquired later due to another condition or treatment. Secondary deficiencies are much more common and are often mild and temporary. The clinical hallmark of immune deficiency is the development of unusual, recurrent, or severe infections. T-cell deficiencies typically lead to viral, fungal, yeast, and opportunistic infections. B-cell or phagocyte deficiencies increase susceptibility to bacterial infections that require opsonization. Complement deficiencies impair the immune system's ability to clear pathogens, especially those with protective capsules. Primary immune deficiencies are rare disorders, usually caused by single gene defects that impair the body's ability to defend itself against infections. Although some of these conditions may not appear until later in life, many present during infancy or early childhood. Primary immune deficiencies are classified into major groups based on which part of the immune system is affected. These groups include combined deficiencies, antibody deficiencies, phagocytic defects, defects in innate immunity, and complement defects. Combined immune deficiencies involve defects in the development of both T lymphocytes and B lymphocytes. One of the most severe forms is severe combined immunodeficiency, or SCID. Individuals with SCID have very few detectable lymphocytes, an underdeveloped thymus, and significantly reduced or absent levels of IgM and IgA antibodies. Without intervention, SCID is fatal in early childhood because the body cannot mount any effective immune response. Other combined immune deficiencies include bare lymphocyte syndrome, where individuals have enough T and B cells but cannot properly coordinate their activity because of missing MHC molecules. Wiskott-Aldrich syndrome features low IgM levels and increased bleeding due to platelet abnormalities. DiGeorge syndrome results from the absence or underdevelopment of the thymus and parathyroid glands, leading to profound immune and calcium regulation problems. Predominantly antibody deficiencies are the most common primary immune deficiencies. These conditions result from defective B cell development and can affect the production of one or multiple types of antibodies. Hypogammaglobulinemia refers to low antibody levels, while agammaglobulinemia, such as Bruton agammaglobulinemia, means an almost complete absence of antibodies. Individuals with these disorders are highly susceptible to recurrent bacterial infections. Phagocyte defects impair the body's ability to clear pathogens through ingestion and destruction. These defects may involve insufficient numbers of phagocytic cells or abnormal function. Chronic granulomatous disease is a notable example, caused by a defect in the oxidative burst needed for microbial killing. Affected individuals suffer from recurrent infections, particularly pneumonia, and may develop tumor-like granulomas in the lungs, skin, and bones. Defects in innate immunity disrupt the body's first line of defense against pathogens. A major example is chronic mucocutaneous candidiasis, in which individuals suffer from persistent fungal infections, particularly with Candida species. These individuals have normal numbers of immune cells but lack the capacity to effectively respond to fungal invaders. Complement deficiencies impact the immune system's ability to clear pathogens and regulate inflammation. The most severe complement defect is a C3 deficiency because C3 is central to activating all complement pathways. Individuals with C3 deficiency experience recurrent life-threatening infections. Another complement defect, mannose binding lectin deficiency, primarily affects the lectin pathway and increases vulnerability to infections by encapsulated bacteria. Treatment for primary immune deficiencies focuses on replacing the missing or defective components of the immune system. Options include intravenous immune globulin therapy to supply functional antibodies, stem cell transplantation to rebuild the immune system, transfusions of erythrocytes for blood-related deficiencies, and bone marrow transplants. In some cases, mesenchymal stem cell injections may also be used to promote immune recovery and reduce inflammation. Secondary immune deficiencies, also called acquired deficiencies, are far more common than primary deficiencies. These deficiencies usually result from another illness or external factors such as malnutrition, stress, or medication use. Often, secondary deficiencies are mild and temporary. However, in severe cases, individuals become highly susceptible to infections. Severe acquired deficiencies can occur with malignancies, immunosuppressive treatments, or advanced infections like AIDS. In malignancies, immune function is often suppressed, especially during late stages of cancer. Tumors can directly impair immune responses, and the treatments for cancer, such as chemotherapy and radiation, further damage immune cells. In fact, many cancer patients ultimately die from infections rather than from the tumor itself, highlighting the critical role of immune defense in survival. Certain medications intentionally suppress the immune system to manage diseases such as autoimmune disorders or to prevent organ transplant rejection. Common immunosuppressive agents include corticosteroids, chemotherapy drugs, radiation therapy, and anti-rejection medications. Although necessary in many cases, these treatments can significantly weaken the body's ability to fight infections. AIDS is the most advanced stage of infection caused by the human immunodeficiency virus, or HIV. HIV attacks and depletes the body's T helper cells, leading to a generalized immune deficiency. As the number of T helper cells declines, the body becomes increasingly vulnerable to opportunistic infections and certain cancers, eventually resulting in life-threatening illness if untreated. HIV is a blood-borne pathogen that is primarily transmitted through heterosexual contact worldwide, although other transmission routes include sharing needles and mother-to-child transmission during childbirth or breastfeeding. In many parts of the world, particularly in sub-Saharan Africa, women are disproportionately affected by HIV infection. HIV is a retrovirus, meaning its genetic material is stored as RNA rather than DNA. The viral RNA is packaged within a protective capsid and surrounded by a lipid envelope. Embedded in this envelope are glycoproteins, specifically GP120 and GP41, which are critical for the virus's ability to bind to and enter target cells. Inside the virus are enzymes like reverse transcriptase, integrase, and protease, each essential for viral replication. This slide illustrates the complex structure of the HIV virus. At its core, the virus contains two strands of RNA and the enzymes needed for replication. Surrounding the core is a protein capsid and an outer lipid envelope studded with GP120 and GP41 glycoproteins. These structures are vital for binding to and infecting target cells, particularly the body's T helper cells. The HIV life cycle begins when the virus attaches to the surface of a T helper cell using the GP120 protein. After attachment, the viral capsid enters the cell's cytoplasm. HIV's RNA is then converted into DNA using reverse transcriptase. This viral DNA is integrated into the host genome by the enzyme integrase, allowing HIV to hijack the host cellular machinery to produce new virus particles. These new virions are assembled, bud off from the cell, and can then infect other cells. Once new virions are released, they carry a piece of the host cell's membrane as their outer envelope, making them less recognizable to the immune system. Because HIV integrates its genetic material into host DNA, it becomes extremely difficult to eradicate. This is one reason why HIV infection, without treatment, eventually leads to a progressive decline in immune function. Early clinical manifestations of HIV infection are often mild and nonspecific, resembling a flu-like illness. During this stage, an individual may be serologically negative, meaning that no detectable antibodies are present. Later, individuals become serologically positive but may remain asymptomatic for years. As the disease progresses to AIDS, opportunistic infections, unusual cancers, and debilitating chronic illnesses emerge, signaling serious immune system collapse. The diagnosis of AIDS is confirmed when a person's CD4 T helper cell count falls below 200 cells per cubic millimeter of blood. Treatment for HIV infection includes antiretroviral therapy, or ART, which uses a combination of medications. These drugs target various stages of the HIV life cycle, including entry inhibitors, reverse transcriptase inhibitors, integrase inhibitors, and protease inhibitors. Although ART significantly reduces HIV-related mortality, it is not curative, and lifelong treatment is required. In children, HIV is most often transmitted during pregnancy, delivery, or breastfeeding. Without treatment, pediatric HIV progresses rapidly, and neurologic involvement is common. Early diagnosis and immediate initiation of antiretroviral therapy are critical. With appropriate treatment, the risk of mother-to-child transmission can be dramatically reduced, and affected children can lead longer, healthier lives.